Hello Phaco Mentors community, this is Dr. Ivo Ferreira evaluating a case. In this case, we're going to see a phaco emulsification. We start with an incision, and here we're going to stop to understand a couple of things. Okay, first thing, we have a big knife in which if you really think it's a very long knife, which can compromise the incision that it's going to be too long in that cornea. It's very important to understand the different types of knives and how not only the width but the how long they are. Of course, this looks like a young patient with a very resistant cornea, or that knife doesn't have the cutting power enough. So what you see is a surgeon that it's going to make probably a long incision, which can compromise not only capsulorhexis with the forceps, but also when you're doing phaco. It's important also to understand that the eye has a mild miosis, around 60 to 65%, and we can see a cortical cataract that is not very dense. Okay, and it's very important to see that we also see signs of pseudoexfoliation. So this case is gonna have some complexity when you're facing it. What we saw is that the incision was very long. We put trip and blue, viscoelastics, do the paracentesis and stop. Here you see a lot of viscoelastic running out of the incision, which is very important to understand. Why? Because now you don't have that force pushing back into the lens, and the vectors are going to try to run to the periphery of the incision. As you can see, we do a first flap in which we create a vector that is very important. You always need to try to have a vector that is already parallel to the iris, okay? And in this case, it's still radial, and the surgeon is going to try to do it. Another important thing you always need to see is the size of the forceps. You see a big forceps for that incision. So what's going to happen, it's not easy to manipulate. Remember that we're going to be always watching the floating and the pivoting through the incision, and when you have a big forceps, it's going to be difficult to do it. So right now, what the surgeon needs to do is to create that vector to make it parallel to the iris. You grab it and you're having good control. You see short movements, you see, but also viscoelastic running out and running out. You see short movements, which I like. I don't care how many movements you need to do. I care about the outcome. So what you see is a sharing technique that rhexis is folded, and here the surgeon is taking the time to see correctly where you're going to grab it, and you have a correct capsulorhexis. I really like it. I like it that it's centered to the visual axis. I like the size and I like the shape. So the outcome of the capsulorhexis was good. Very important to have it. Now we're gonna proceed. Well, the surgeon is removing some viscoelastic, which I like, so you don't have a posterior capsular blockage. And now we are trying to do a hydrodissection, so that cannula is below the capsule, a little bit up, but what happened here, you didn't have enough volume and enough speed in order to do the hydrodissection. There you see with that, you saw not only the wave but the change of characteristics of the lens. Keep going, but what I really like is to always, when you inject, depress the center of the lens, because you don't want to accumulate that liquid below the lens and to have a posterior capsular blockage. Okay, very important to do. So again, I would like to depress that lens a little bit more, and also to always be aware that when you see the wave, you can start rotation, of course, with a lot of care and very careful, so you don't damage the zonula. Okay, we didn't see the rotation perfectly, but you see a lens that, you know, it's free. Part of it is in the anterior chamber. It's okay. Stop, because here you see that the lens it's already vertical, in a vertical position. When you have a lens in a vertical position, it can be good in the way that you're not going to be able to compromise the posterior capsule, but you also need to be aware that you're working close to the endothelium, and the inflammation can be stronger. Here you can also see a balance tip from Alcon that it's not positioned in the right way, because that balance tip needs to be positioned completely vertical with that curve. Also, you see the irrigation going directly to the endothelium, which you don't like, because you want to have that that irrigation to the side. Also, because you have the lens that is that is vertical and not in the bag, the iris, I can tell you that it's going to start to, you know, become smaller, which is going to, you know, increase the risk of the surgery. It's important that in the beginning, with aciduous foliation and with an iris that is going to get smaller, you either have to put adrenaline and have it ready, or even to put iris hooks since the beginning. Okay, keep going. Now you can see the surgeon that without the technique is trying to remove that lens, going into the lens to try to go in position to occlude it and emulsify it. Which I like is going very slowly, taking the time, okay, going slowly. Remember also it's important that you have epinucleus and nucleus, which have different densities, and you need to be aware of that. Now you're putting viscoelastic to protect the endothelium and also the posterior capsule, which I like. Moving the lens a little bit. Again, the irrigation is directly aimed to the endothelium, which I don't like. But taking the time, emulsifying that lens, going for the nucleus, as you can see, and as I told you in the beginning, what you see is, you know, the iris going smaller. Now you have more viscoelastic, and what we believe is maybe there is some compromise in the zonula. You can stop right there. You're seeing a movement that is different. You're seeing a movement that is different in that iris. So because we saw there was aciduous foliation, there is probably a compromise in the zonula, and you need to be very careful, because again, here you need to have a couple of things in mind. First, of course, you don't want that lens to go back, but if you only think about that, you can create a compromise in the rest of structures, which you don't want. We were discussing about that, okay? So if you're working very close to the endothelium, probably that endothelium, you know, is going to suffer. So yes, you don't want that lens to go back, but also you need to be very aware of that endothelium for the future. Okay, so you're working too close to the endothelium. Again, going very slowly for the nucleus. You can see those movements in the iris, and you can see that the pupil shrinking. Okay, and also you can see that that anterior chamber is not behaving correctly, and definitely you can see that there is some compromise in the zonula because of the behavior. Oh, look at that. You see? And you see the behavior of that bag that is very unstable, and the shrinking, and it's because probably a compromise in the zonula. What I like here is you put viscoelastic before you leave, but you should be more. And then, oh, definitely there, stop. You can definitely see that in the left side of that eye, you have a big compromise in the zonula. Okay, so this is a moment to stop and to reassess, to put viscoelastics in the bag, and we need to do something about it. What we can do in this moment is to put a CTR in the bag in order to create more tension in that bag, to remove the cortex, and then assess if you're going to be able to put a 1-piece IOL in the bag or a 3-piece IOL in the sulcus. As you can see, you have a compromise that probably is more than 120, 130 degrees. Stop. That's something I don't recommend in this case. In this moment, if you think about it and you think about the vectors, you cannot try to remove cortex exactly in the place that you have a zonular dialysis and weakness. Why? Because you're going to bring the entire bag with you. And let's see what happens. But well, the surgeon is taking the time and probably has the correct settings, which is good. Yeah, but the cortex is not coming, and probably it's gonna come the cortex and the bag. Okay, tell me what happens if you don't have a CTR. Well, probably in some cases you don't have a capsular tension ring. What I should do is I will stop a little bit. I will stop and put iris hooks to the bag to try to maintain the bag at that moment. That the iris hooks are easy to have. They're cheap and they can be a lot of help. Keep going. And as you can see, look at that bag. I mean, you're removing some of the cortex, but the capsule is so unstable that you're putting more traction into the bag, and probably what's going to happen is you're going to de-insert the entire capsule. And again, stop a little bit, because this is a moment we have always, and all of us, been here, that it's a moment in which we are nervous, and a moment that we are very stressed and our decision making goes down. Okay, and the most important part here is what I call the stop and stand back technique, which is put viscoelastic, remove everything, assess the situation, have some breathing strategies, and make the best decisions. If you keep going, probably your decision making is going to be very compromised. And as you can see, stop right there, because here you can have the false sensation that you are removing the cortex, but actually you are not only removing the cortex. What's happening there is that the bag is completely compromised, and now what you're seeing is the vitreous cavity. Okay, so now that bag that could be safe, and we could put a CTR or put iris hooks at least to remove the cortex and then put a 3-piece IOL in the sulcus. Now we're losing that chance. And as you can see, now we probably have a lot of vitreous present, and you can see some vitreous there. Look at that. Look, do you see what you saw? You're not only seeing viscoelastic right now, you're seeing all the pressure from the vitreous coming to you. Okay, now stop, because when you have the suspect that you have vitreous in the anterior chamber, there is a way on how to transition from phaco to anterior vitrectomy. To transition from phaco to anterior vitrectomy, the first thing you do is you remain in position 1, and it doesn't matter if it's INA or phaco, you remain in position 1 so you can have more stability of that anterior chamber, and then you put a lot of dispersive viscoelastic to push everything back. Then you remove everything, and then you're going to start working through paracentesis Why? Because you're going to put triamcinolone, you're going to put viscoelastic, you're going to use the anterior vitrector, and those instruments are 1 millimeter of diameter, and your incision is 2.2 or 2.8. So what I strongly recommend in this transition is to put a lot of viscoelastic, dispersive viscoelastic, because what I saw is mostly cohesive viscoelastic coming out. And the second thing is you're gonna do a stitch in the main incision and then do a paracentesis and work from there. So you're putting triamcinolone, and you also see a lot of pressure coming out of the eye. Okay, triamcinolone is going to be good to visualize vitreous. As you can see, there is even vitreous in the main incision. Okay, this is good. You are doing a paracentesis, but with a not stable anterior chamber. So, and you stop right there. That you're doing a second paracentesis or making the first paracentesis bigger. We need to be very careful with the diameter of this, and I will never do anterior vitrectomy through the main incision, at least not without a stitch. So I will do the stitch before I'm doing this. Okay, in the main incision, I will always put the vitrector through a paracentesis. Even if I have that vitreous, I will eat that vitreous from the another side of the incision. Okay, so because there you're tractioning vitreous and you're having negative pressure to do it. Okay, this is good, but I should, this is something I will do much earlier. I will actually do it after the transition, do a good suture in the main incision since the beginning, use a lot of viscoelastic not to decompress the chamber, and I really like to use triamcinolone to see vitreous. Okay, so right now, here stop, because this is very important. We tend to do the vitrectomy from the top of the eye, and remember, this is why American ophthalmologists do pars plana vitrectomy, because they want to come from the bottom of the eye. So always you need to see the hole of the vitrector, not to push it down. And what I will do is I will start going deep, because I want the vitreous to go back instead of keep coming up. Okay, so always seeing the hole of the vitrector like this, always like this, and I will go down, not being afraid to go actually to the center of the eye, and take a lot of time with, remember, the settings are going to be a high cut, low vacuum, low aspiration rate, and low IOP in that anterior chamber. And I will do a complete anterior vitrectomy. Again, the movements are going to be very controlled, very smooth, very slight, because you don't want to traction vitreous. Okay, you don't want to take vitreous from the posterior capsule to the anterior capsule. I will take my time, always cutting, high cut. As you can see, vitreous tends to come to the negative pressure, and this is probably because you did a second paracentesis, which is much more wider than the irrigation. So that's negative pressure, and the vitreous is gonna keep coming to negative pressure. Again, for do an anterior vitrectomy, you must have a completely stable anterior chamber. Okay, this is exactly what I was thinking. You were having a lot of negative pressure there, so you need to suture the paracentesis. What I like is the surgeon takes the time in order to do this, and this is a moment to be relaxed and to take as much time as possible and use a lot of viscoelastic, okay, to keep going. Again, this is an eye that if we do things right, it's gonna go great. We're gonna, the cataract is out, we're gonna do a perfect capsule anterior vitrectomy, we're gonna reduce inflammation, and then we can do a secondary IOL implantation, or put an artisan lens in the iris. We can do great. We need to have that in mind at all times. But here the key is to take as much time as we need to remove all the vitreous from the anterior chamber. All the vitreous. We're gonna remove it, we're gonna take our time, and then we're gonna think in the future to implant an IOL, either with a Yamana technique or everything. As you can see, I like air bubbles a lot because they're gonna tell you, you know, if you have vitreous or not, if the main incision it's free, and it's gonna also push vitreous back for the future.